Welcome back to Diabetic Files. I am so sorry for the hiatus. I have been traveling. I'm literally doing this from a hotel. And yeah, kids, academics do take you places. So today actually is a very special day. It's my daddy's birthday, and I wouldn't be here if it wasn't for my dada. Unfortunately, he passed away in 2024. I don't know how to explain it, but he's amazing. He was everything to me. He was a doctor. That's the only reason I'm a doctor because he helped me through it. I remember my dada told me I was like so attached to my mommy and daddy growing up. They really sheltered me. I was like super attached to them. So when I left for college, it was like a culture shock to leave the Bahamas and go to Ohio and live there, and I just wanted to be with my mommy and my daddy, and I couldn't stop from crying every day, and then one day, I'm crying to my daddy, and I just wanna go home. He's like, "Yep, we can bring you home, Gabby, but do you wanna come home or do you wanna be a doctor?" I'll never forget that, and I said, "I wanna be a doctor." He said, "So you didn't see it." And then my daddy said, "So I guess you're gonna stay there." And I was like, "Okay." And he's the one who brought me through it. I wouldn't be here today if it wasn't for my daddy and my mama, but my dada, he's my rock. He's my everything. I couldn't do it. This man, he went to Meharry, my daddy, Dr. Elwood Donaldson, went to Meharry, OBGYN. He actually delivered me. Yeah, that's my dada. Yeah. He's amazing. The men that were brought up around that time, they're a different breed, like, they're real, like, decent men. But let's get into it. So today's episode is what is your pain telling you? Because I always say because of neuropathy, when a patient starts feeling pain and they have neuropathy, I see that as a really bad sign. I'm like, "Uh-oh," you know? So let's go quickly into it. I will try my best to do 2 episodes before I have to get to work, but yes. So, pain. It wakes you up at 3 AM, it can make you limp, and it can make you stop. But what if I told you pain is not the problem? Pain is actually a message. And in the world of diabetic foot care, sometimes the biggest danger is when the message is silent, aka when we have neuropathy, right? So, welcome back to Diabetic Foot Files. I'm Dr. G, and today's episode, we're going to talk about what is your pain telling you. So, this is not about discomfort, this is about decoding our survival signals before they become amputations. So, let's talk a little bit about the evolution of pain. Pain is ancient. That's how we were brought up, right? That's how we were made to have pain. So, before imaging, before labs, humans had to rely on pain to survive. Step on something, you withdraw, right? Burn your hand, you pull away. Infection, pain forces us to rest. Pain is a protective reflex and a behavioral teacher. So here's the clinical twist. Modern medicine often tries to eliminate pain, right? Instead of interpreting the pain, because we take a lot of like people take a lot of pain pills. Let's say my finger hurts right now, I think from me traveling and heavy lifting. And yeah, I had to take an anti-inflammatory because the pain was so bad. But also think I might have cracked my nail underneath and I can't see, but I can only tell because of the pain. So I have to remove my nail along that area. But the key concepts are pain has three layers: the detection, the nociceptors, the transmission, the nerves and the spinal cord, and the perception, the brain interpretation. So there are types of pain. So the language, pain is like a dialect. Pain is a dialect, and we need to understand pain's different accents. For me, I love me a British accent. So, sharp pain. Sharp pain is acute alarm. So, things like knife like pain, localized pain, immediate pain. So, let's say a diabetic patient steps on a tap, but feels it late. The interpretation, most likely the patient has partial neuropathy and the injury is still acute. Burning pain, a lot of diabetics experience that, the neuropathy signature. So feet on fire, worse at night, tingling and numbness, often symmetrical. A lot of times neuropathy is on both sides. It's never I rarely see neuropathy on one side, and if it's one side, it's usually like nerve impingement, things like that. Okay. But no matter or nerve entrapment, but no matter what, you should be referred to the neurologist and they could do a nerve conduction test. But burning pain we often indicates nerve degeneration. Electrical pain, like electric pain, like the shooting, radiating, sudden pain, we ask that to patients. Think of nerve compression and advanced neuropathy. Throbbing pain. I ask patients, is it throbbing? That is like throbbing is pulsatile. It's like a heartbeat, it's like boom, boom. And deep pressure sensation often means abscess forming, infection building. I had a patient like that, and I was just like, oh, there's like an infection building because they have neuropathy and the throbbing, but we had to relieve it. I had to get the hemostat. Yeah. Okay. Deep ache pain. Most likely that's bone involvement. So hard to localize, persistent, red flag, usually osteomyelitis. Ischemic pain, worse at rest, better when you're hanging down your leg. Uh, When that happens, and then the foot is cold and pale, vascular, 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 vascular emergency signal. Okay, but I'm being honest. I want us to all get to the point where this isn't. You don't get to that point. I want us to get to the vascular way before that point. That's the whole point of me constantly saying vascular. Like when you think of diabetes, yes, think of podiatrist, but when you think of diabetes, yes, think of your vascular as well, okay? So, the biochemistry of pain. Pain is chemistry. The key players are prostaglandins, bradykinin, substance P, and cytokines. These signals amplify signals, lower pain threshold, increases inflammation. So the clinical tie-in is that's why infected wounds hurt more, right? And I love when my patients say, "Oh, it doesn't hurt anymore," especially after a nice IND. I love that. And I'm like, "Oh, so how's your pain?" "Oh, yeah, no, I didn't even need to take medication." I love that. I'm always so happy. I'm like, "Yay, we're on the right track." Inflamed tissue becomes very hypersensitive. Pain intensity often correlates with inflammatory load. So let's talk about the silent foot with neuropathy. Now that's the dangerous part because in diabetes, chronic hyperglycemia damages the nerves and microvascular supply decreases and then the signal transmission fails. And the result is peripheral neuropathy. And forgive me for, I hope I'm not rushing, but I'm trying my best to get this in before I have to get other stuff done and go downstairs. So the paradox is early injury pain level is usually high. They say danger low, but nah. Condition, let's say advanced ulcer, usually the pain level is low unless it has a new infection, right? But the danger level is high. And then osteomyelitis, sometimes they feel pain, sometimes they don't. But with osteomyelitis, the danger level is always going to be super high with osteomyelitis. So let's do a quick case study. A patient walks into a clinic, no pain, small ulcer under the metatarsal head, but it probes the bone. Diagnosis: if it probes the bone, most likely osteomyelitis. But the lesson is no pain does not mean no problem. And that's the problem that we have a lot with patients. They don't know. And that's why you have to check your feet every single day. That is your task as a diabetic. Every day, check the bottom of your feet. Okay. Check the bottom of your feet because I don't even check the bottom of my feet. Forgive me. That's a little hypocritical. But I only check if I step on something. So I don't want y'all to do that. I want you to check your feet every single day. And remember, the lady said, put a mirror in front of your like toilet bowl so that when you're sitting on the toilet, you could just lift up your foot and be able to see because then you're killing two birds with one stone because who doesn't need to use the toilet, right? Okay. Pain in infection. Pain changes as infection evolves. So stage one, usually inflammation, right? So that's mild pain, redness, and warmth. Then stage 2, cellulitis, so like spreading pain, swelling, tenderness. Stage 3, abscess, like throbbing, pressure, and severe pain. Stage 4, hopefully we don't get out of that. To this, pain out of proportion. Usually that's a necrotizing infection. Severe deep pain, tissue may look normal early, and that happened. Like you have to investigate, and that's why I always tell people do not overlook a patient's pain and just be like, "Oh, you've been walking on it too much." Mm-mm. Pain is always a signal. Like, I'm like, when I hear they have pain, "Oh, it has a little pain over." Yeah, let's figure this out before it gets worse. So, clinical rule is if the pain doesn't match the wound, it's something deeper. Now, ischemic pain. This is vascular. This is vascular area. So, like rest pain, especially at night, relief when the leg is dependent, cold, pale, bluish foot, right? It hurts because there is lack of oxygen, there's tissue starvation, and nerve ischemia. So the patient may complain, my foot hurts worse when I lay down. That's not a neuropathy, that's arterial insufficiency. And central versus peripheral pain, not all pain is from the foot. So peripheral pain, usually local tissue damage. Central pain is usually the brain and spinal cord interpretation of the tissue. So example is phantom limb pain after amputation. We did an episode on that. The brain still feels the limb, right? So when pain is subjective. So factors that can also affect pain is anxiety, depression, cultural tolerance, right? Some people have a really high pain tolerance, previous trauma, things like that. But the clinical pearl is two patients, same wound. One patient can scream in pain, one patient can feel nothing. You must assess beyond the pain score, okay? So, what are some of the red flags we need to look out for? Pain is screaming for help. Your body is screaming for help one way or another. So, anything sudden, severe onset, pain and fever, pain and swelling and crepitus, pain out of proportion, and new pain in a neuropathic foot, especially in a neuropathic foot. So, keep that in mind. And when it comes to decoding the framework, when it comes to decoding a patient pain, we ask, where's the location, right? Location, quality, timing, severity, and progression. So let me say that again: location, quality, timing, severity, and progression. So, and then you think, is it mechanical pain, neurological, infectious, or vascular? Because pain is its own diagnostic algorithm. So let's do a quick story case. So this is going to be quick advanced burning pain in feet bilateral at night, most likely neuropathy. Painless ulcer, advanced tissue damage. Throbbing pain, most likely an abscess. And you're like, oh, how did it form an abscess? Breast pain, critical limb ischemia. So I hope this reinforces that I say pain is a narrative, okay? Pain is not a punishment. Pain is actually like your body really trying to communicate with you. Pain is communication. And that's why they say communication is key, right? It's your relationship with your body. It's the body literally trying to communicate with you like, "Hey, something's not right. Can we fix this? Can you put attention on it? Okay? Can you take me to the doctor?" But in diabetes with the neuropathy, the silence does delay the communication, and that can cause amputations, delayed assessment, and medical help. So listen to your body carefully. Every ache, every burn, even the absence of pain, okay, is telling you something. And this is Diabetics with Files, where wounds speak and we actually listen. And I'm Dr. G. I would like to say where I am right now, but yeah. But this is Dr. G, and take care of your feet because they take care of you.